Hello, I'm Joseph Alpert, Editor-in-Chief of the American Journal of Medicine, and today I'd like to call your attention to an article that I found very interesting in this month's AJM. It's from Paul Stein at the Michigan State University College of Osteopathic Medicine. Dr. Stein is one of the world's authorities on pulmonary embolism, and this was a very interesting one. They have a very huge database that they're a very large database of pulmonary embolism patients collected generally, I think, through healthcare statistics and insurance and so forth that have been collected for many years. They looked at a 15-year period starting in 1999, and they looked at outcomes of pulmonary embolism in the patients in this data set. And they've done a number of these articles, some of which we've published in the AJM before. Here they were particularly interested in high-risk pulmonary embolism, the kinds of patients who are significantly distressed and often usually go to the ICU for their care of this pulmonary embolism. These are large burden PE patients. Well, the question was, how are we doing? Are we doing any better than in 1999? And the interesting answer was we're doing much better. So the mortality for high-risk pulmonary embolism in 1999 was almost 75%. And the mortality in 2014 was up around 50%. So there was a substantial improvement. So you might say, well, it must be all the new therapies. Well, there were no new therapies between 1999 and 2014, but there was a huge improvement in ICU care. So the conclusion was, yes, we do much better with the very high-risk pulmonary embolism patients. And the reason is because we deliver very excellent ICU care. And I think every one of you who work in the ICU know that that's largely due to better monitoring. And really the most important thing is outstanding nursing care, highly sophisticated, really super good nursing care that picks up complications just as they're starting and intervenes. And that's made a huge difference. And historically of interest, that was what happened in the CCU too. The benefits when the first CCUs came along were because you had highly trained nurses who could act according to protocol. They didn't have to just call the doctor and say, what should I do? So this is further evidence that these ICUs with their highly skilled nursing and monitoring equipment really make a difference in terms of mortality, in this case, in high-risk pulmonary embolism. Please stay in touch with us. American Journal of Medicine has a lot of social media, Facebook and Twitter and our website and so forth. So please read the journal and stay in touch with us through all of our social media.